Hello, you're welcome to the final part of the lecture video series on primary health care, and we've been looking at the aspect of training and support of the PHC workers through this lecture series. And in this part 4, we are continuing with the challenges faced by the PHC workers. And we'll be using a pyramid layer to be able to describe these challenges. Thank you for watching the other part of the videos, and I believe that you enjoyed it. Please remember to like, to share, and also to subscribe to the YouTube channel. My name is Dr. Isaboyin Henry, and I'll be going into details of this lecture using these slides. And so I will be talking about lots of examples that you would need to take note of. Please ensure that you take notes and also do some other findings by using your textbooks and also other research to get more details. So let's visualize these challenges facing the primary healthcare workforce using a pyramid. As you can see on this slide, this pyramid helps us understand that overcoming systemic challenges at the base is critical because they form the foundation supporting all other issues higher up. So at the bottom, you have the systemic challenge, which is funding, policy, and training. In the middle, you have the operational challenges, which is the workload, resources, and supervision. You have the community-based challenge at the top, which is characterized by cultural barriers, trust, and safety. So we'll be looking at the pyramid of challenges. And we'll begin with the base, which is the systemic challenges. And you know that the base, known as the foundation, is most critical. And so at the very bottom, we have systemic challenges, which are the most fundamental. Without addressing this area, other problems cannot be sustainably solved. And so you have the problem of inadequate funding for PhD programs, and this limits the salaries. You have a problem of incentives because it will limit the incentives. It will also limit the infrastructure and the essential supply. So without sufficient funding, workforce motivation and retention will suffer. We also have the weekly policy framework. That is, a weak policy framework will result in unclear recruitment standards, inconsistent training programs, and limited career advancement opportunities. And this will lead to workforce instability and variable, service quality. And finally, we have, as part of the problem, limited training infrastructure in this systemic challenge. And this means fewer qualified trainers or outdated or inconsistent curriculum, and scarce training centers will become the order of the day. I know what this means. It will prevent PhD workers from gaining the skills they need to perform effectively. So you can't joke with these systemic challenges. It has to be resolved. Because as long as it is not properly resolved, operational challenges will remain and community-based challenges will get worse. If you look at the middle layer, you have the operational challenges. Once the foundation is shaky, operational challenges will arise. Here you will have high workload. You have insufficient resources and logistics. You have weak supervision and mentoring. In terms of workload, this occurs because staff shortages will push workers to handle multiple roles, and this will lead to burnout and reduced quality of care. In terms of insufficient resources and logistics, like lack of medicines, transport, or equipment, it will hinder the PhD workers' ability to fulfill duties reliably. In terms of weak supervision and monitoring, it simply means performance gaps will go unnoticed, and the feedback loops for improvement will become missing, and this will reduce accountability. If you look at the top layer, that's the community-based challenges. Finally, at this point, the pyramid's peak includes community level barriers. And you have issues of cultural beliefs and practice as part of the challenges at the community-based level. You have low trust. You have concerns about personal safety. Now, when you say cultural beliefs and practices, this will discourage early health-seeking behaviors or create resistance to certain interventions like vaccination. And when you have low trust in PHC workers or government health services, this will reduce community engagement and adherence to health advice because they won't believe them anymore. They don't trust them. They don't see them as serious people. And when it comes to concerns about personal safety, especially for workers in remote or conflict-affected areas, it will deter the PHC workers from moving forward, from taking action, and this will disrupt services. So you see, the pyramid shows that sustainable improvement in PHC require first strengthening the base systemic factors like funding, policy, and training. Only with a solid foundation can operational efficiencies and community engagement thrive, and creating a resilient healthcare system. Looking at slide 35, we want to break down the specific challenges primary healthcare workers face using this organized layer. Now, if you look at the pyramid that we discussed earlier, it is important that we understand it very well, because understanding these challenges as seen in the pyramid will help us to see where interventions are most needed. We'll begin with the base layer again, systemic challenges. Now, we talked about inadequate funding, and we have said that limited financial resources mean that the PHC often will lack essential supplies like drugs, vaccines, and protective equipment. And when there are no protective equipment, it will draw them back. They will not be able to, take charge, take responsibility because of fear for their life. It also affects their salaries and incentives, and this can lead to low morale and even attrition. They withdraw. For example, in many low-income countries, delayed salary payments cause workers to seek alternative income sources. And this will reduce their focus and availability for community care. When they are supposed to be at their position, they are posed to do their job, they go about looking for other means to make money. We also see the problem of policy gaps. Policy gaps under the systemic challenges now. We see the problem of policy gaps. Now, without clear policies formally integrating the PHCW into the health system, their roles can be unclear if you don't have a good policy. They come in, you now have cases of overlapping, which will create confusion and weak accountability. And so this uncertainty can demotivate workers, and it can affect consistency in service delivery. In the case of training deficiencies, when training is irregular or insufficient, the PHC workers may lack confidence and critical skills needed for their diverse roles. And you see, you have cases of outdated curriculum or lack of refresher courses. And this will further widen the skill gaps, and it will impact the quality of care because they do not get the required updates that they need. So this is very, very important. So 1 minute, please. So let's talk about the middle layer now, that is the operational challenges. Here, like I said before, you find cases of excessive workload, where the PHC workers now often handle large patient volumes across broad geographic areas. And these heavy workloads will lead to fatigue and burnout. So you see a PHC worker covering multiple villages, and they spend more time traveling up and down and consulting more patients. And this will limit service reach because there are many others still waiting and there are less PHC workers. We also see resource scarcity. That is, the lack of medical supplies, diagnostic equipment, and reliable transportation compromises the ability to provide timely and effective care. We also see limited supervision. And this is where mentorship and mentoring becomes weak, because everybody is busy and nobody is monitoring what is going on anymore. So this lack of guidance reduces motivation and will hinder professional growth, affecting overall standards and accountability in the health system. Now, if you look at all that we have talked about now under the operational challenge, and also both the middle layer and in the okay, let's take just for the middle layer alone before we move to the other aspects. In this area that we have discussed, in the middle area, we have seen that these systemic and operational barriers, they are very, very much linked together. Very, very much linked together. And they reinforce one another. So, without a clear policy, sufficient funding, and effective supervision, even the most dedicated PHC worker will struggle to maintain a high quality and sustainable service delivery. And addressing these challenges will require a comprehensive approach that strengthens both systems and day-to-day operations. Now, still looking at the challenges, we want to see the top layer now. We want to focus on the top layer of the pyramid, and that's the community-based challenges that PHC workers encounter daily. Now, these challenges often stem from social and cultural dynamics and can significantly affect low health services, and also can significantly bring about a disruption in the flow of work or delivery of health service to that community. Now, looking at the top layer, again, the community-based challenges, you have problems like the cultural barriers, deep-rooted traditional beliefs, and those local practices sometimes conflict with modern health advice. And this makes it difficult for the PHC worker to implement interventions. For example, in some communities, traditional birth attendants may be preferred over trained health workers. And this will limit uptake of facility-based maternal care, because you can't compare the traditional birth attendants and the trained health workers, the certified health workers. So overcoming these barriers will require PHC workers to engage respectfully and work alongside community leaders so that they can build acceptance. On the other hand, we have the trust issues. Misinformation and skepticism about health programs reduce community cooperation. So when rumors around vaccines or treatments spread, people may distrust the PHC worker or refuse to participate in public health initiatives. For instance, during polio vaccination campaigns, mistrust fueled by misinformation caused refusals in parts of Nigeria and Pakistan. And now this has brought about the next concern, which is now safety concern. Remember, in the top layer, community-based challenges, we have the cultural barriers, trust issues, and now the safety concerns. In fact, the trust issues have led to the safety concerns because the PHC workers often work in environments with exposure risk, both from infectious disease and unsafe infrastructure. Traveling long distances on poor roads or into conflict-prone areas, this can put them in physical danger. So personal safety concerns can discourage PHC workers from operating in high-need regions for the sake and safety of their lives. For example, during the Ebola outbreak in West Africa, between 2014-2016 Ebola crisis, these workers were on the front lines facing multiple community-based challenges. The stigma was there. They experienced severe social stigma as communities feared that PHC workers might spread this virus. So this isolation made their work emotionally difficult. Some had to be separated from their family for a long time. You also have the high exposure risk. Many lacked protective equipment initially, increasing their risk of contracting Ebola. You also have the emotional strain. And this emotional strain, honestly, beyond physical risk. The PHC worker had to conduct education and contact tracing amid widespread fear and panic. This is a huge task that demands resilience and strong community communication skill, even despite such emotional challenge. So you see that in this top layer, the pyramid teaches us a crucial lesson. Addressing systemic challenges at the base like funding, clear policies, robust training is the first step. This creates the conditions for operational effectiveness and enhanced community trust, enabling the PHC worker to overcome cultural and safety challenges on the ground. In this slide, we want to see the measuring of the primary healthcare workers' success. And in doing that, in measuring the success of primary healthcare workers' programs, it's essential to understand their true impact on community health and guide future improvements. You don't just send them out there to keep working. You have to monitor their work. You have to measure the success. You have to guide them, see the impact on the community. So let's explore how impact is assessed through health outcomes and service delivery metrics. So measuring success outcomes evaluation often looks at a tangible improvement in community health. And they include reduction in maternal and child mortality rates. And number 2, they include decrease in preventable diseases. Number 3, improved life expectancy and well-being. These are the 3 areas that are seriously looked into, because when they are looked into, they are easily used to be able to measure the success or the health outcomes when evaluated in that community to see if they've made tangible improvements. So service metrics along with direct health outcomes, you have evaluation tracks being built, and this will show how the health services will improve. So vaccination coverage and antenatal care attendance rise when the PHC workers engage effectively with the communities. And increased access and awareness will also be improved. And when this gets improved, it will lead to a high health literacy and behavior change, because they are educated now, and a lot of wrong lifestyle will be put aside because they have good health literacy level and their behavior will now change. It will also improve referral linkages because there will be strong coordination between the PHC workers and the health facilities, and this will ensure that patients receive appropriate care for more complex conditions. Now, we have a case study here, like in India, the ASHA program. The Accredited Social Health Activists program contributed to a 30% reduction in neonatal deaths by promoting maternal care and early newborn interventions. In Ethiopia, the Health Extension Program, through intensive community training, immunization coverage, increased, their performance, such that the immunization coverage was seriously and dramatically increased from 30% to 70%, improving child survival significantly. You also have that in Bangladesh family welfare assistance, where they focused on family planning and immunization, and it led to a notable decline in infant mortality rates. So here we see that accurate monitoring and evaluation framework will enable policymakers and program managers to track progress, to be able to identify gap, and to be able to make evidence-based decisions. And this will ensure that the PHC workers program gets adapted and in a way that it will strengthen their contribution toward achieving the universal health coverage, where everyone receives the health services they need without financial hardship. Now we want to look at slide 38. So here we want to see the comparative impact, infant mortality rate. So let's zoom in one of the powerful indicators of community health, the infant mortality rate, and see how primary health care worker programs make a difference. So we look at these tools, which is the very most important one. I repeat, infant mortality rate is a very strong tool for, evaluating progress or outcome of the health workers. Now, with PHC workers programs in regions of India where the accredited social health activist program was implemented, IMR dropped significantly from 65 deaths per 1,000 live births in 2005 to 40 deaths per 1,000 live births by 2015. You can see that in Betial et al. 2019. Why does this matter? Why is it that it is important to look at the infant mortality rate as a tool, as an indicator of community health? This improvement comes from increased access to maternal health care services, skilled birth attendance, and timely childhood immunization, all driven by the PHC workers who engage communities directly and build trust. Now, what does this show? When you see these successes, it shows that despite general improvements in healthcare infrastructure, areas without active PHC workers' involvement face persistent gaps in service coverage and health education, and this will lead to slower progress. Why do we say this? A practical example is the one that happened with the ASHA workers because the ASHA workers visit pregnant women at home. They educate mothers on nutrition and newborn care and encourage facility-based deliveries instead of doing it at home with their birth attendants. And this is known to reduce mortality risk. But without the PHC work programs in comparable regions that had no structured PHC work initiatives, the decline in infant mortality rate was much slower, from 70 to 55 deaths per 1,000 live births over the same decade. You cannot compare it to that of improved one of 65 to 40. So you see that it is important that we see the effect of the PHC workers. When the structure is there, they play a key role, and then you see a good impact. So the key takeaway here is that areas with robust PHC workers' engagement will experience faster and more substantial reduction in infant mortality. And this highlights the essential role in achieving sustainable development goals, that is the SDG 3.2, which is to end preventable deaths of newborns and children under 5 years of age. Looking at slide 39, another comparative impact is what we want to look at now. And this is focused on immunization coverage, just like the other one, slide 38, was focused on IMR. So let's examine another crucial measure of public health success, which is immunization coverage, and how primary health care workers programs make a powerful difference in protecting children. So, immunization coverage with PHC workers program. Ethiopia's health extension program achieved an impressive rise in full immunization coverage, jumping from just 30% in 2004 to 2004 to 70% by 2014, according to WHO in 2023. How was this success achieved? Trained community health workers played a pivotal role by conducting door-to-door outreach, educating families about vaccine benefits, and also doing routine follow-ups to ensure that all the children in that community completed their immunization schedules. This personalized approach built the trust and overcame common barriers like misinformation and logistical challenges, because the PHC worker was always around. And so if they had any doubt, they asked the question. He wasn't missing, and then the wrong persons were supplying wrong information. A clear practical example is a health extension worker who visits new mothers at home and then explains the importance of vaccines and reminds the new mother of her clinic appointment dates. This way, closing gaps in immunization timelines. She won't forget. She won't be discouraged. Somebody is monitoring, somebody is encouraging her. But let's look at a situation where there are no PHC worker programs. Yeah, a situation where there are no PHC worker programs. Remember, we're carrying out a comparative impact. Neighboring regions lacking such community-based initiatives showed a slower improvement from 35% to only 50% coverage during the same decade. Why is there this difference? Why the difference? Because limited outreach activities, low awareness about vaccination benefits, and weaker connections between healthcare providers and the communities made it challenging to reach all the children, especially in rural or marginalized areas. So a key takeaway is that community-based interventions led by PHC workers significantly accelerated immunization coverage, reducing the burden of vaccine-preventable diseases, and these efforts are vital for meeting sustainable development goals, especially the SDG 3.8, which focuses on achieving universal health coverage, including essential vaccines for all children. Now we come to slide 40. Here we want to also see another comparative impact. This time is maternal mortality ratio. The maternal mortality ratio reflects the number of maternal deaths per 100,000 live births. We will be looking at a case where there were PHC workers program and when there were no PHC work program or village health workers program, as it were. In Bangladesh, the development of family welfare assistance was instrumental in reducing maternal death between 2001 and 2010. The MMR declined significantly from 322 to 194 per 1,000 live births. So how did the FWSA, or we call it the PHC work program in Bangladesh, that is the family welfare assistance, how did it work? How did it make a difference? Through regular home visits, the FWAs provided maternal health education, promoted antenatal care, and encouraged referrals for skilled birth attendants. Their early identification of pregnancy complications led to timely medical intervention, which saved many lives. So you see that the FWAs helped expectant mothers understand the danger signs, such as bleeding or severe pain, and motivated them to deliver in health facilities rather than at home with birth attendants. In places where there were no PHC workers program, Similar regions lacking organized community health work support saw only a modest MMR decrease from 350 to 250 per 100,000 live births in the same period. And what contributed to this slow progress? Limited maternal health knowledge in communities. That was one of the things that contributed to the slow progress. And also the reduced access to skilled health care providers, which they could ask questions, which they could take advice from. This resulted in delayed or inadequate treatment of pregnancy complications. Again, as a takeaway, countries investing in training and deploying the PHC work achieve faster and sustainable reductions in maternal mortality. And this reinforces the vital role of culturally sensitive grassroots engagement in achieving sustainable development goals. 3.1. And that is to reduce global maternal mortality. Again, let's look at, under slide 41, disease incidence. We are still looking at the impact of the PHC workers and the evaluation of their impact. The PHC workers programs have impacted disease incidence. And using malaria as a key example of preventable endemic illness, we see that in Rwanda, community health workers initiative focused on early diagnosis, home-based treatment, and widespread distribution of mosquito nets. And this strategy led to a remarkable 35% reduction in malaria incidence between 2005 and 2010. Why it worked? It worked because the PHCW provided timely testing and education, ensuring cases were detected and treated early, while preventive measures like mosquito net use were promoted directly in homes. This local proactive approach interrupted transmission cycles and then it saved lives. So this is a practical example. Community health workers conducting household visits to test febrile children with rapid diagnostic tests, RDTs, and supplying insecticide-treated nets increased both prevention and treatment coverage. But in a case where there were no PHC program, in comparable regions without active community health programs, only a 15% reduction in malaria incidence was observed over the same period. And what were the reasons for this slower progress? There were delayed diagnosis, low preventive coverage, and poor community awareness, which limited the effectiveness of malaria control efforts. Without trusted local health workers, many cases remain undetected and untreated early. There are other examples like that of Bangladesh, who sustained the PHC workers' engagement in home-based care and immunization, and it contributed significantly. Also in South Africa, the integration of mobile data collection tools by the PHC workers improved tuberculosis treatment adherence by 50%. And this boosted disease surveillance and ensuring patients really, were followed up so that they can complete their treatment in the TB treatment plan. So what is the key insight here? The PHC workers-led interventions are not only cost-effective, but they are transformative. By reducing disease burdens and strengthening community resilience, they play a fundamental role in tackling preventable illnesses and advancing public health goals. This is very, very important. You can see this slide. These are PHC workers. Probably they had a celebration, and those who have done excellently were rewarded, and they had a refreshers course where they discussed challenges, they discussed the successes, and they evaluated the progress that they have made so far. Now we want to see the recommendations and the policy directions. The recommendations and the policy directions. Remember that there are practical ways to make the work of primary health care workers more effective and sustainable. And these practical ways are not just in theory. but firmly grounded in real-world practice. And so, number one is integration into health systems. The PHC worker must be fully integrated into the national health systems rather than treated as sideline or temporary workers. So what does this mean? It means aligning the PHC worker's role with national health policies, ensures clarity in responsibilities, developing formal job description and supervision mechanisms and career pathways that will help them grow professionally within the health sector. And we have seen this done in countries like Ethiopia, and thank God it's been done in Nigeria, and they are growing. And see, this integration declares the PHC worker as essential healthcare team member, not just volunteer or informal actors. Number two is incentivization. Motivation matters. Sustaining PHC workers' commitment requires meaningful incentives. You have to give them a fair remuneration. Number two, you have to give them recognition. So when you offer them certificates, awards, these are clear opportunities for advancement, and it will build pride and reduce turnover, especially in remote or challenging environments. Number three is technological integration. And this is where digital innovations are revolutionizing the PHC delivery. Here, mobile apps and mobile health platforms are engaged so that they can be able to, facilitate data recording, reporting, or on-demand refresher training for PHC workers. You also have the real-time supervisor communication. While they are doing, they can be communicating with their mentor, with their supervisor, real-time. So this approach has transformed the PHC services in countries like Nigeria, Rwanda, Kenya, Bangladesh, where mobile technology supports everything from immunization tracking to outbreak response. We also see that this technology have bridged gaps that geographic or resource limitation would otherwise, have imposed. So these gaps are no longer challenges. Number four, we have the community ownership. So when you sustain PHC work programs, then you know that to sustain it, it will rely on genuine community participation. So when communities perceive the PHC workers as their own people, as their own program, they see them as people who came from their community, trusted. They will take that program serious. And you see such program will gain lasting strength and relevance. Also, establishing community feedback system will empower people to voice their concerns and suggest improvements. And that way, it will tailor services to local needs effectively. So what's the takeaway on this slide? A strong, motivated, and well-supported PHC workers network will bridge the gap between health policy and frontline practice. This is essential for achieving universal health coverage and advancing sustainable development goals. Also, investing in integration, giving incentives, providing technology, and community ownership will create resilient health systems capable of meeting diverse population needs. We move to the slide 44. Now we want to see a policy framework for effective PHC workers integration or village health workers integration. Let's explore what a strong policy framework for integrating primary healthcare workers should look like. For countries aiming to strengthen their primary healthcare system, especially in rural or hard-to-reach areas, policies must be clear, well-structured, and supportive. Number one, they need the clear role definition and standardization. So clarity is clear. It's key. Every PHC worker needs to understand exactly what their job involves. They need to get the scope of work. The policy should clearly define the PHC workers' responsibilities, such as health education, basic medical care, immunization, and so many others. There need to be clear, written, standardized training. The PHC worker must receive uniform, competency based training nationwide, not different in states. Whether Sokoto or Bayelsa, the quality of service should be consistent. Training should blend theoretical knowledge, practical sessions, and regular refresh courses, not just one-off workshops. And why does this matter? When roles and training are standardized, supervision becomes more straightforward. Performance will improve, and communities will develop stronger trust in the primary health care workers' service. Next, we want to see the integration into the health system. So let's break it down. If primary health care workers are going to be effective, they must be fully integrated into the national health system, not treated as an afterthought. Not treated as an afterthought. So there should be that formal recognition. And this is key because the PHC workers shouldn't just be helpers. They are frontline health professionals and they need to be officially recognized within the national health workforce structure. That means being part of health planning, budgeting, decision-making processes. So when they are recognized, their work becomes more visible and valued. And it's easier to monitor performance and scale up their success. Again, they need supervision and support. No health worker should be left to work alone. We've said it again and again. The PHC worker needs structured supervision where senior officers provide mentorship, guidance, and feedback. They also include continuous professional development. Number 3, sustainable financial and incentives. This is adequate compensation. Sustainable financial incentives. One major reason community health programs fail is because workers are poorly motivated. So if the workers should receive fair pay allowances or incentives that reflect their effort and impact, even if they are volunteers, non-monetary rewards like recognition, training, and career progression can go a long way. Don't forget also resource allocation. Resource allocation. Governments must set aside dedicated funds for this set of workers' training, logistics, and medical supplies. Without proper financing, even the best designed community health program will struggle to survive. Therefore, in summary, when the PHC workers are properly integrated, supervised, and supported financially, the entire primary health care system becomes stronger, more efficient, and more sustainable. We also see community engagement and ownership. Community engagement and ownership. And this takes place via participatory selection and also improved by feedback mechanisms. Now, when we say participatory selection, it involves community members in the recruitment and selection of the PHC workers to foster trust. You have to identify, do you know these people? Do you trust them? Are they of good record? And there's a feedback mechanism. This will create structured platforms such as community meetings, surveys, or suggestion systems that will allow the continuous community feedback on their PHC workers' performance and service delivery. Another policy direction is the monitoring and evaluation. Monitoring and evaluation. Here we use the performance metrics and we also use the data integration. When you use the performance metrics, it will establish clear indicators to evaluate these PHC workers' effectiveness, their service coverage, and the contribution to improve health outcomes. In terms of data integration, it will ensure that data collected by PHC workers are incorporated into National Health Information System, and it will enhance decision-making, policy development, and adaptive improvement. For slide 47, there we see another direction, which is policy and legislative support. And this will require regulatory framework. Countries need to enact and enforce clear policies that will define the PHC workers, like we've already said. And then we have the advocacy and awareness. They need to promote the importance of these workers among policymakers and public so that they can gather support and recognition. And so implementing such a framework can enhance the effectiveness and sustainability of village health work programs or PHC programs, leading to improved health outcomes and progress toward universal health coverage. So, implementing a robust policy and legislative framework will strengthen the PHC workers' programs by enhancing their effectiveness, boosting motivation, and ensuring long-term sustainability. Now, this foundation is critical for making measurable progress toward improved health outcomes and achieving universal health coverage. To deepen our understanding and ground your work in evidence-based perspective, I'd like to advise here are some essential scholarly resources on integrating primary healthcare workers programs into national health systems. So you can look at them. There are different documents. We see that each of them I was able to put what details that it reflects so that you can understand and you look for them. Now, one of them is integrating national community-based health workers programs into health system. It's a systemic review identifying lessons learned from low and middle income countries. It was published in the BMC Public Health Journal. Now, this study offers comprehensive insights, so you can look for it. It's available online and you can study it. You have another one, the health system strengthening through policy level integration of community health workers programs. You can check for them. You have that published in the Frontiers in Public Health Journal. So you can take time to look at that. You also have another one, community health workers programs integration into national health system. It's a scoping review. You can look for that document and you can learn more, because it provided evidence of community health workers programs integration, and more information, more details you will find there. So, in conclusion, primary healthcare workers are truly the backbone of community-based health services. They serve as essential bridges connecting underserved communities, underserved populations with the formal healthcare system. Their contributions are wide-ranging and critical, from health education and disease prevention to providing basic medical care and collecting health data. The PHC workers play an indispensable role in advancing universal health coverage and global health goals. Maximizing their impact will require several key elements: comprehensive and continuous training, robust support systems, and policy integration. Empowering these PHC workers isn't just a policy option. It's essential for building resilience, equitable, and sustainable health systems worldwide. We have seen the history of public health, particularly in Nigeria and other low-middle income countries. And we have seen that primary healthcare worker programs have emerged as vital responses to the persistent challenge of limited access to healthcare services. Programs such as Nigeria's Community Health Influencers, Promoters and Services CHIPS initiative, and that of India's Accredited Social Health Activists program have demonstrated the transformative potential of primary healthcare workers when properly trained, supported, and integrated into the national health systems. And so to sustain and scale these successes, the following remain essential: effective training and continuous professional development, consistent supervision and mentorship, robust logistic, emotional, and professional support, addressing systemic barriers such as inadequate funding, poor integration, and limited resources. We also see that community acceptance and engagement are essential, very, very essential. We've seen also that PHC workers initiatives must be context sensitive. That is, tailored to the socio-cultural realities of each community. And this includes active participation of community members in the selection, supervision, and evaluation of these PHC workers, so that to strengthen trust, accountability, and sustainability. Ultimately, if you integrate PHC workers into national health systems, supported by clear policy framework, sustainable financing, and structured career development, you will provide a pathway to stronger and more equitable health outcomes. Therefore, by empowering these PHC workers through continuous training, fair compensation, and recognition, governments and health organizations can unlock their full potential to transform healthcare delivery in underserved and hard-to-reach regions. So, the primary healthcare workers at this juncture truly embody the health of grassroots healthcare, and they bring essential health services, genuine compassion, and vital knowledge directly to those who need it at most. Their dedication and strong community trust and close accessibility make them irreplaceable. Yes, irreplaceable agents of change. And they are key to bridging health inequities. The inequities and reinforcing public health systems, especially in underserved areas. And they have come to a level where we've seen that the sustained impact is important. We cannot let those impacts be gone. We have to keep building on them. So empowerment is the key. Empowering the PHC workers means empowering healthier communities and building stronger nations. So when we invest in these frontline heroes, we invest in a future where equitable healthcare reaches everyone and everywhere. So, I want to believe that you have enjoyed this lecture. You will observe 10 MCQ questions in the next slide. So let's look at the post-evaluation. What is the primary focus of the CHIEFS program in Nigeria? You can see the questions there. Now you can see the answers. Number 1, number 2, you can see number 3, which of the following is not a role of PHC workers? You can see that the answer is there, A. And you can see number 4, which global health initiative generally influenced the establishment of village health workers or PHC workers? The answer is B, the Alma Ata Declaration. So you can see number 5, number 6, the answers and explanation is also there. Number 9 and number 10. And then you can see this handsome PHC workers. You can see their vibrancy, you can see the positive vibe, you can see the transportation means and their package, their dressing, and they are trusted, they're wanted in the community. So these are the references. I want to thank you for staying with me through this lecture, and I appreciate you. If you love this video or you've learned anything, please, you can click the like button. You can also subscribe by clicking the bell button, and also share to other students and colleagues. I will really appreciate that. And I hope that we've done justice to this topic, training and support of PHC workers. And I know that you will be of relevant input to your study and will impact your training. Thank you, and have a wonderful time studying and going through your training. Bye.